بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على نبينا محمد وعلى آله وصحبه أجمعين. Good evening, ladies and gentlemen, and welcome to this evening's webinar hosted by the Saudi Commission for Health Specialties. We're happy to be with you this evening. And share with each other what we have so far regarding pregnancy and COVID-19. So first of all, I'd like to introduce our speakers for this evening. We have with us Professor Nabeel Bondagji. Professor Nabeel is a professor of obstetrics and gynecology, and at the same time, he's a consultant in maternal-fetal medicine at the College of Medicine in King Abdulaziz University in Jeddah. He has many, many years of experience. He's one of the pioneers of maternal-fetal medicine in the Kingdom of Saudi Arabia. And he's going to be talking with us this evening about specifically about medications, whether they are COVID-19 specific medications or obstetric medications in pregnant women. Also with us this evening, we have Dr. Eman Alsulmi. Dr. Eman Alsulmi is also a consultant in maternal-fetal medicine and an assistant professor of obstetrics and gynecology at Imam Abdurrahman bin Faisal University in Dammam. She works at King Fahad Hospital of the university. Dr. Eman is also the chair of the Saudi Society of Maternal-Fetal Medicine that has been recently formed and is leading with regards to pregnancy care here in Saudi Arabia, especially when we're talking about high-risk pregnancy, pregnancy with medical complications or fetal complications. So with that, we will start with our first speaker, who is Dr. Eman Alsulmi.
Assalamu alaikum wa rahmatullahi wa barakatuh jami'an. Shukran jazeelan, Dr. Yasser, for this introduction. If you guys just give me a second, I'm just going to share my screen. And we're going to start flying, inshallah, bidnillah ta'ala. So, I hope that you guys hear me well. So, Bismillah ar-Rahman ar-Rahim. Again, thank you for the introduction. And as Dr. Yaser Faden had stated that we're going to be talking about the pregnancy and COVID-19. We're going to look into the challenges and what are the recommendations that have come up from the Saudi Society of Maternal-Fetal Medicine. Try to now. I have nothing to disclose, no personal conflict of interest for today's talk. Before I go into my talk, I just want to lay for you what is this evening is going to look like. First, we're going to look where do we stand today in Saudi Arabia. What have we done as a Society of Maternal-Fetal Medicine, as a Saudi Society of Maternal-Fetal Medicine, to face the pandemic? We're going to look at the background on COVID-19, a little bit of basic virology, concerns in pregnancy. We're also going to look into pregnancy management during COVID-19 pandemic. Dr. Prof. Nabeel Bondagji, he's going to discuss with you COVID-19 therapy in pregnancy, obstetric medications, and chronic medications management in general. Dr. Yaser Faden, he's going to talk about management of critically ill pregnant patients, and he's going to discuss in detail labor and postpartum consideration for suspected and confirmed COVID-19 cases. Now, where do we stand here today in Saudi Arabia? Coronavirus disease or COVID-19 was first identified in Wuhan, China in the late 2019. Since then, it has globally spread and declared by the WHO as a pandemic last month, March 11th. Um, Numbers in Saudi Arabia has been steadily going up, and as we see from the curve, the blue line, we don't have, alhamdulillah, any acute surge or a steep increase, but cases are going still up. As of today, the total number in Saudi today confirmed cases were about 7,000 or just above the 7,000. We have passed the 2 million worldwide so far. So it has been the time for us as a society to do something about it. We believe firmly that knowledge is the strongest weapon we can use to win this pandemic fight. Educating ourselves first, other physicians, and public is one of the society core goals. The Saudi Society of Maternal-Fetal Medicine, as Dr. Yaser Faden was recently formed under the umbrella of Saudi Commission for Health Specialists. With the COVID-19 pandemic, the society assumed its natural role of directing physicians and educating the public in the face of this pandemic. SSMFM formed a task force on March 21st, 2020 to develop a guidance to provide safe care to pregnant women in the Kingdom of Saudi Arabia by exploring a recent evidence that may help us in preventing the transmission of COVID-19 first, and also offering management recommendations for those who care for suspected and confirmed cases. The task force was not a one-man show. It was led by Dr. Faden and consists of Prof. Nabeel Bondagji, Dr. Fadwah Tahir, Dr. Nadia Alghilan, Dr. Samiha Alawami, Dr. Hythem Alsum, Dr. Yasir Katib, Dr. Yasser Sabr, and myself. You can go to the Twitter account of the SSMFM to access this guidance. The society have also contacted the MOH to express its willingness to help and advice in the developing of any further MOH guidance and guideline on COVID-19 and pregnancy. We have also used the social media platform to educate pregnant patient women. We are working on infographics to be distributed for the public to encourage social distancing and healthy behaviors during this pandemic. We've also been participating in the resident teaching 2 weeks ago. Residents have presented their talk on guidance for COVID-19 and pregnancy. This presentation was uploaded to the SSMFM community channel on the YouTube. Before I go into my talk, I just want to look into the objectives of my part of the talk this evening. We are going to review together the basic related virology to COVID-19. We are going to also address concerns regarding COVID-19 and pregnancy. I've already seen people asking about vertical transmission. We're going to discuss that, congenital anomalies, increased risk, maternal risk itself, and pregnancy risk in general. We're also going to discuss pregnancy antenatal management during COVID-19 pandemic. Before I start into any talk, I usually go into the etymology of a word itself. And from Latin, corona mean crown. Therefore, literally, coronavirus are named for the crown-like spikes on their surfaces, as you see from that picture. There are four main subgroups of coronavirus known as alpha, beta, gamma, and delta. There are 7 known coronaviruses that can infect people, mostly the alpha ones and beta, and they're referred to as human coronavirus. The 3 common ones that we are more familiar with are MERS-CoV, the beta coronavirus that causes Middle East respiratory syndrome, or known as MERS, the SARS-CoV, the beta coronavirus that causes severe acute respiratory syndrome, or known as SARS, and the SARS-CoV-2, severe acute respiratory syndrome coronavirus 2, the novel coronavirus that causes coronavirus disease 2019, or known as COVID-19, on the topic of our today's talk. Now, SARS-CoV-2, a novel enveloped RNA beta coronavirus, infect host respiratory epithelial cell through angiotensin converting enzyme 2. This is important to know in obstetric literature. Cellular studies revealed that the expression of AC2 is attenuated in female, in keeping with the epidemiological observations that the majority of COVID-19 infections to date have occurred in men. We have to keep in mind that this is just not proven yet, and we have seen a severe form of the disease in female and in young population as well. The average number of people that one person with a virus infects in susceptible population based on the R naught scale. And for COVID-19, the R naught is 2 to 2.5 or to 3 average people infected from one infected person. The incubation period, it's about 2 to 14 days, and a study showed that a patient can continue to shed the virus as evident by the RT-PCR remaining positive for about 20 days after the disease resolution. And in some of the literature had stated it's up to 36 days even. Person-to-person transmission is now known to occur via respiratory droplets through close proximity with prolonged close contact within the 1.5 to 2 meter perimeters. Aerosol transmission is possible, but thought to be with aerosol generating procedures like intubation and bronchoscopy. Until now, there is a lack of clarity currently revolving around whether the second stage of labor should be considered as an aerosol generating event. There is a possibility of dissemination of the virus when a patient is forcefully exhaling with pain during active labor or pushing in second stage. And all our patients are actually usually huffing and puffing while they're pushing. We have to keep in mind when aerosolized, the virus can stay in the air for up to 3 hours. Hence, all of us as a healthcare staff attending women in active labor, staying with them for sometimes 2 hours or more, need to don full personal protective equipment, including the respirator N95 in an affected patient. Fomites are described to carry the virus and causes transmission. And we see here from the picture that in some surfaces, the virus can stay on the surface for some materials as plastic and stainless steel for up to 3 days. So good hygiene practice should be practiced in view of this pandemic. Still up until today, there are no reports on transmission via airborne and fecal oral route, although there has been reports of isolating the virus in the stool, and the stool samples remain positive in 50% of patients who have recovered, and some of the neonatal literature that showed the neonate positive for coronavirus found that they were, or COVID-19, they were the anal swabs for these neonates were as positive as well. Disease onset is typically seen within 1 week of exposure. As I said previously, the incubation period between few days to 2 weeks. 80% will have mild to moderate disease with high rate of spontaneous recovery within 2 weeks. The 14% of patients may fall into a severe disease, and 6% could be critically ill, requiring mechanical ventilation. And these are, we have to remember that they're in general population. Pregnant patients have a different numbers. Patients who fall into either one of these two categories, the severe or critically ill, typically require about 3 to 6 weeks to recover. In terms of case fatality rate, general population accounted to, or according to the CDC, is it's approximately about 1%. But when I looked at the epidemiological studies, they calculated the CFR, or the case fatality rate per total cases, gives a different number depending on the region, and roughly it's anywhere between 0.25 to 4%, and it depends on if it's a literature earlier when the disease was initially discovered and the testing was not widely available, and later right now. Now, the RT-PCR assay is the current gold standard for detecting the SARS-CoV-2 from a respiratory specimen in a patient with suspected COVID-19. Same is used for pregnant population. In a recent study out of the US published a few days ago in the New England Journal of Medicine showed that when universal screening is applied to all pregnant women presenting to maternity unit for delivery, about 15% found to be positive for COVID-19, and the majority of them were asymptomatic, up to 88%. We have to be cautious when we interpret such data and study. Uh, Either way, we have to be careful when we attend labor for our patients, when we don't apply universal testing by wearing a proper PPE, and maybe a surgical mask is enough when patients are not in the category of suspected or confirmed cases. In symptomatic pregnant patients, common clinical features are not different from the non-pregnant population, and including actually their common ones that usually seen, as you see in this table, fever, dry cough are the primary symptoms, along with non-specific symptoms like fatigue, myalgia, malaise, chills. There are recent emerging evidence that GI symptoms, including nausea and vomiting and diarrhea, might be a more important presenting symptoms than what we initially thought. Severe symptoms have also been reported in pregnant women, particularly those with comorbidity, such as the asthma and diabetes, and they're not a small number of our patient population. In this table here, we see the clinical features of COVID-19 and pregnancy stratified against the SARS and MERS cases. Apart from the symptoms that we have just discussed in the previous slide, chest imaging found to be abnormal in up to 80%, and some of the studies, they said up to 100% of general population, but up to 80% in pregnant population, and may aid in the diagnosis, but does not replace the molecular confirmation of the COVID-19. Other laboratory tests include lymphopenia, which has been reported in these patients' population as well as in general population. When leukocytosis is seen, you have to entertain the presence of secondary bacterial infection. Reports of liver involvement in form of elevated transaminase and coagulopathies, as well as decreased platelet, has been seen in our pregnant patients, which is in our group of pregnant population. It might confuse us with the preeclampsia and the severe entity of this disease. At least 4 registries found collecting cases: the US registry, UK obstetrical surveillance system, Netherlands registry, and international registry. But so far, as we've probably aware, none have yet published result. The Netherlands published or publishing a result now, but it was not in English. Below are total numbers from scientific reports, avoiding duplicating as much as possible. Although when looking at the Chinese literature, there was a lot of duplication in reporting the cases between the literature. Cases only reported in these total the ones that in medical literature, the ones that they were reported only in the newspaper and social media were excluded. This work is done by Professor Jim Thornton. He's a professor in obstetric and gynecology in Nottingham. The total number of pregnant women with confirmed COVID-19 cases were 318, 212 delivered, 72 vaginal delivery, accounting for about 34% of total cases, and 141 had a cesarean section, accounting for about 66%. And recently, there was 1 maternal death out of Iran. I'm going to talk a little bit more about it in the following slide. So what have we learned from that in regard of obstetrical patients? Although still early data and difficult to judge, COVID-19 outcomes for a mother appears more promising compared to SARS and MERS. At present, there is no evidence that pregnancy increases a woman's risk of acquiring COVID-19. And I've seen this one question was asked initially before we started this webinar. So yes, we do not have yet evidence to prove that there are pregnant patients at increased risk of acquiring COVID-19 or even developing severe symptoms from the disease. Pooled data by Dashrath et al. Revealed a case fatality of 0% when it comes into COVID-19. Of course, this was before the Iran case, and it's accounted for about, our case fatality rate was about 18 and 25 in SARS and MERS, respectively. 2% of patients has been reported falling severely ill, requiring mechanical ventilation in COVID-19. Most recent updates reports found that COVID-19 in pregnant patients can cause severe maternal morbidities in up to 9% of affected gravid. C-section rate was high, as we've seen in the previous slide, more than 60%, and it was as high as 90% seen in some reports out of China. And that's might be because of regional differences. When I looked at dissected the literature, a lot of indication for the C-section were stated as maternal pneumonia, although the patients were not on mechanical ventilation, and some were stated as preterm delivery or PPROM. So it's slightly different demographics and lower threshold for C-section there. A maternal death from COVID-19 in Iran reported in Travel Medicine and Infectious Disease Journal a few days ago. A 27-year-old woman at 30 weeks gestation presented with severe respiratory failure. She required intubation and ventilation. A few hours later, she delivered a stillborn baby vaginally. And a few hours after that, she died, Allah yarhamha. Post-mortem on the mother confirmed SARS-CoV-2 in the lungs. No further details were given about the baby. This is the first academic report, as opposed to the ones that they were just reported in the news, of a maternal death due to COVID-19. As the AC2 receptors are widely expressed in placenta, the risk of vertical transmission is theoretically possible. The available data revealed that the virus was not isolated from amniotic fluid, cord blood, and a neonatal throat swab. Therefore, vertical transmission is still remain unknown, or even presumed not present. However, a recent reports by dog described a case of a neonate born for COVID-19 infected mother who tested positive for SARS-CoV IgM. There are also reports in the press on a neonate testing positive about 30 hours after birth in China, and another one in the UK immediately after C-section, but we don't have great details on the later one. Yeah, no amniotic fluid, cord blood, or placental result were reported in any of these positive cases. So at present, because the lack of evidence related to vertical transmission and no report supporting that the virus is teratogenic, therefore it is believed there is no increased risk of fetal congenital anomalies in these patients' population. As you can see in the table here on the right, pregnancies affected by coronavirus infection in general, including the COVID-19, have a higher rate of preterm birth, but not clear if it is was spontaneous or iatrogenic. In pregnancy management during COVID-19 pandemic, I will be talking about the SSMFM proposed antenatal care model for women not suspected or confirmed to have COVID-19 during a pandemic. I will also discuss the antenatal care for women with suspected or confirmed COVID-19 and briefly touch on the hospital care for such cases, but I'm going to leave the detail to Dr. Yaser Faden when he talks about management later. Now, in a pandemic, we all know now that social distancing measures have proven to be effective in reducing disease transmission. And an effort to try to flatten our curve in Saudi here, the traditional antenatal appointment schedule, which contain more than 14 in-person visits, may need to be modified to minimize direct contact while maintaining still adequate maternal and fetal care. In the inverted pyramid of antenatal care proposed by Sonak and colleagues in 2011, they recommended an early visit between 11 to 13 weeks gestation when pregnancy dating, prenatal blood work, and risk assessment can be done. If the patient is deemed to be a low-risk patient, her subsequent visits can be arranged at a follow-up gestational age of 20, 37, and 41 weeks gestation. Hospital have to understand their patient's population and resources to come up with a system that provide antenatal care while enhancing social distancing. A suggested care model that combines both telehealth and in-person visits and is actually summarized in this table here. In high-risk patients, care should be individualized and tailored to patients' needs and fetal conditions, and in-person visits should be replaced with a telehealth when possible. So in this table here, you see that all patients between 11 and 14 weeks has to be seen in person, and this will be their booking visit, dating ultrasound, risk assessment, antenatal routine blood work done. And then again, between, you don't have to see your patient until 6 to 8 weeks later, between 20 to 24 weeks, when you see them again for their anatomy scan. And in that visit, you also do the rest of the obstetrical assessment. And you may actually give your patient her immunization, the NTD if the patients are Rh negative, and arrange for the OGTT to be given if you were seeing your patient around 24 weeks. And then if all that's done at 26 to 28 weeks, you don't have to see your patient in person. It can be done as a telehealth. Again, at 32 weeks, it can be done as a telehealth as well. You should see your patient again in person around the 37 weeks to do your GPS swab and then plan the mode of delivery. Subsequently, you could talk to your patient through telehealth weekly until 40 or 41 week when you should see her again, and if she's not delivered, and plan the delivery and do your biophysical profile. 4 to 6 weeks postpartum, all these visits should be done via telehealth, and if patients chose to go for contraception, her medication can be picked up from a pharmacy that close to home or sent to her via transporter from the hospital. Now, until now, we do not recommend universal testing and screening for pregnant population. They should be tested according to the case definition that's put out by the Ministry of Health and changed frequently, and we have to keep ourselves updated every time they change it. Especially the regions that considered high risk within the kingdom. Therefore, patients' risk for COVID-19 should be assessed prior to their hospital visit for antenatal care or coming for labor and delivery. In suspected pregnant women, investigation and isolation should be implemented according to the MOH protocol. They also apply to who should be tested in general. Now, you also are, all of you probably familiar that respiratory triage checklist has to be followed to stratify our patients to which is case definition. And then if you define your patient, you fill in this coronavirus disease 2019 Appendix 1. And in this form here in Appendix 1, you find that actually the Ministry of Health had stated that pregnancy is one of the comorbid conditions, and these patients have to be hospitalized. And I'm hoping that I'm actually really happy to see this, because with such mandatory reporting, it won't be difficult for us here in the kingdom to start a national registry in collaboration with the Ministry of Health, inshallah. For now, all confirmed pregnant patients are recommended to be admitted and managed as inpatient. All antenatal care appointment should be rescheduled after recommended period of isolation or until the patient is tested negative. Given how little we know actually about this infection, a detailed mid-trimester anatomy ultrasound examination may be considered following the first trimester maternal infection. For those experiencing illness later in the pregnancy, perhaps in the third trimester, it is reasonable to consider ultrasound assessment for fetal growth in the third trimester. These appointments can be arranged preferably at the end of the working day, and always keep the same team to minimize exposure. The multidisciplinary team, when a patient is admitted, should be involved in the care, should consist of maternal-fetal specialist, if available in the hospital. Obstetrician should be informed, infectious disease specialist, intensive care specialist, anesthesiologist, and neonatologist. They should be triaged and stratified into one of the four categories. The mild ones are the symptomatic or mild symptoms with stable vital signs and no comorbidities. The moderate ones are the mild symptoms with stable vital signs and a comorbidity. The severe category are based on the ones that have finding of respiratory distress with a heart rate more than 30, or oxygen saturation less than 94%, or FiO2 or less than 300, or lung infiltration more than 50% on the imaging within 24 to 48 hours. Critical patients who are actually show shock or multi-organ failures, or ones that require ECMO. A portable ultrasound machine for fetal surveillance can be assigned to these cases if hospital resources allows to check on fetal well-being when mother is actually stable. Now, for those who were admitted, retesting must be done to patient and start the testing until patient is recovered, and after 48 hours after recovery, you start doing the testing every 72 hours until it's negative, and then you need two negatives samples about 24 hours apart to be able to discharge your patient, and this is from Wiqaya and Ministry of Health. Patients still continue to be isolated for the 14 days of home isolation after discharge. And thank you very much. And I'm going to give the mic back to Dr. Yaser Faden.
Thank you, Dr. Eman, for the excellent presentation. Lots of information that we all need to digest, but they are all very important information, especially at this moment in time with the coronavirus outbreak. So thank you again, Dr. Eman. So now we'll go on with the next presentation, Professor Nabeel Bondagji. He's going to be talking to us about the medications used or that can be used in pregnant patients with COVID-19, whether those medications are COVID-19 specific medications or obstetric medications that we usually use antenatally or even during labor. So Professor Nabeel, please.
واضحة الآن يا
واضحة.
بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه أجمعين. وأنا أولا نحب نشكر Saudi Council for Health Specialty for their effort to distribute the knowledge among the residents and among people and to unify the source of knowledge rather than getting knowledge from sources that are not trustable. We also thank the Saudi Society for Maternal-Fetal Medicine for issuing their statements and for organizing some important meetings to distribute the knowledge about the COVID therapy, COVID infection, whether in pregnancy or outside pregnancy, because we are all in the same boat. So my presentation will be an update on the COVID therapy in pregnancy. I'll start with update covering therapy in general population. All the modalities or all the medications that are described to treat COVID-19 so far till our time. Then the next step, I'll talk about the safety of those medications in pregnancy and whether to use them and whether not, and which one is preferable during pregnancy. The next part of the talk will be about the obstetric medications that we usually use in our practice. Are they safe? Can we use them? Which one is better during the COVID-19 pandemic and in patients, particularly in patients who are affected with this disease? And the last part of the talk will be on chronic medications that the patient might be on when they get the coronavirus. Now, we'll start with the ground rules. Up to date, my search was till April 15th, 2020. There are no approved coronavirus treatment at the present time. So that is, we have to agree on that. You know, there are no approved coronavirus to treat. The COVID-19 treatment might be already existing. We have lots of medications that are going around, and we don't know whether they will work or not. Because of the emergence or the quick emergence of the pandemic, people started, or researchers started testing all their medications that typically used to treat other problems, and started to try to find a medication that works on corona. Now, can we take this, or I can take this out? Okay. Now, the medications that are currently available. Number one, there are 10. You just remember the number 10. There are 10 medications or modalities to treat coronavirus outside the pregnancy. And which one of them we can use in pregnancy, which one we cannot use. The ones that we cannot use, I will tell you, these are contraindicated, and we'll not talk about them any further. The first medications used are antiviral, and of course, the antiviral medication therapy came from the experience with the SARS and the MERS pandemic that happened before in the world. The drug remdesivir is a new antivirus that was used with success to treat SARS and MERS. Now, people are trying to use the same medication to treat corona. So this is one antiviral. The second antiviral drug that is used to treat HIV patient, which is Caltera, composed of 2 combined antibiotics, lopinavir and ritonavir. And the third one is the one that came recently from Japan, and it is called Avigan. And you all heard about this, and some countries are trying to get that, despite the fact that there is no evidence that it is superior to the others. The second medication available is the anti-malarial drugs, chloroquine and hydroxychloroquine, and we'll talk about these. The third drug is antibiotic, azithromycin in combination with hydroxychloroquine. Azithromycin alone is not used to treat COVID-19, but it should be combined with hydroxychloroquine to give an action. And there is a few reports that put some cautions or describe some unwanted outcome from the combination. The third one, or the fourth one, is the disease-modifying anti-rheumatic drugs, Actemera, and that is contraindicated in pregnancy, so we'll not talk about this any further. The fifth drug is beta interferon, and beta interferon is usually not used alone. It is used in combination with the anti-HIV antiviral, so they used it together, and we'll talk about this later on. Statins have been used to treat coronavirus. Statins, the anti-cholesterol or anti-lipids that is used to reduce the cholesterol level, and it is contraindicated in pregnancy. I will not talk about it any further. Anti-parasitic, ivermectin is a medication that is used to treat some sort of parasites, and mainly it is used to treat hair lice, الجمل. The seventh one is the high-dose intravenous immunoglobulin. It is a therapeutic option only for deteriorating patient with coronavirus, and it is experimental. We'll talk about a little, but it is experimental. Human monoclonal antibodies, it's still experimental. We'll talk about it in 2 lines. And convalescent plasma, and it is still experimental, and it was approved in the United States for only very critical individual cases, and we'll talk about this. So the antiviral treatment has been used to treat COVID-19 infection in China, where the source of the pandemic started. In pregnancy, a combination therapy of lopinavir and ritonavir, which is the drug, the combination used to treat HIV, has been preferred drug regimen. The Chinese literature showed that it is known to reduce the duration of recovery. And these two drugs, it was tried in HIV patients, and they are relatively safe in pregnancy. The recommended dose, don't worry about the recommended dose. Let your ID people worry about the dose. But in order to give the optimal effect, the antiviral should be combined with nebulized interferon inhalation. So the combination of interferon and the anti-HIV medication in the form of tablets as well as nebulizer of interferon. Also, this regimen might be used to treat the patients in pregnancy, despite the fact that the antivirus is category C, but because the benefit, the potential benefit of this medication outweigh the risks, so we can use it relatively safe in pregnancy. Remdesivir is a novel antiviral that is given intravenous. So this one has to be given intravenous, so therefore it should be given in the hospital. And it showed an effect on SARS and MERS. Therefore, the Chinese, once the pandemic started, they started to use this drug. It has been used without reported fetal toxicity in some pregnant women during the Ebola virus. So relatively, again, it is safe in pregnancy, you can use it. However, the WHO advised caution and careful benefit analysis before using investigational therapeutics. Unfortunately, almost all the medications that we are going to talk, or we talked about, are still investigational. So the WHO advised to take caution and careful risk benefit analysis apply for all the medications that I talked about and I will be talking about. Avigan is the drug that came from Japan, and they think that it have a good outcome, but the safety in pregnancy is unknown yet, and some of the authorities advise not to use it except in the clinical trial basis. Now, chloroquine and hydroxychloroquine, both were used in the SARS and MERS, and they showed to inhibit the SARS-CoV-2 in vitro. The use of hydroxychloroquine is preferable over chloroquine because the hydroxychloroquine seems to be showing more antiviral activities and less side effects. So if you have hydroxychloroquine, it's better to use it than chloroquine. If you don't, then chloroquine should be fine. Again, the role of these two medications is still under investigation, despite the fact that they are used before, and we are using them in treating malaria patients with pregnancy, and there is no evidence that they cause any problem in the fetus. So the Chinese indicated that the use of hydroxychloroquine and chloroquine again will reduce the progression of the disease and decrease the duration of the symptoms. So now one important point which might be confusing, hydroxychloroquine does cross the placenta and accumulate in the fetal tissue, and has been observed in animal studies that it causes ocular toxicity. However, in human, there is no effect. It does not cause ocular toxicity in human. So in human, it's relatively safe, and this is one of the false positive that the drugs gives us in relation to species-specific response to different medication. The animals responded by fetal ocular toxicities and the human did not. So it is probably safe. Lots of patients used hydroxychloroquine and chloroquine in pregnancy, and there is no suggested increased risk of miscarriages, malformations, stillbirth, IUFDs, prematurity, growth restriction, or neonatal complications. Azithromycin, I think most of us used it a lot in pregnancy to treat different infections. Only very few individualized studies that showed there is an increased risk of miscarriages. However, the majority of the studies did not support these findings. So probably it is relatively safe. So the available data related to the risk of intrauterine death, prematurity, low birth weight, neonatal complications do not suggest any increased risk for any of those complications associated with the use of azithromycin during pregnancy. This is the anti-lice to treat lice medication. Again, it is recently used to treat COVID-19, and the WHO said more research is needed to see if the doses studied were safe and effective against this virus, and the safety in pregnancies therefore till now is unknown. So we have options of safe drugs in pregnancy that we could use. Interferon beta, we use this to treat some medical disease in pregnancy, and the current data till today, there is no available data to suggest there is an increased risk of any pregnancy complications. And as I mentioned before, interferon is used with anti-HIV, antiviral medications in combination to treat COVID-19. So it is safe. Now, which one of the options that we mentioned before is better than the other? So far, we don't know. And based on that, the WHO announced the launch of the World Adaptive Randomized Trial called Solidarity. It consists of 5 treatment arms. The arms that we mentioned early in this talk. The remdesivir, the chloroquine, the drug that used for HIV, and the lopinavir with interferon, and the standard care of practice without any medications. So these are 5 arms, and the WHO will follow patients in the 5 arms, and based at the end of the study, based on the results, they will tell us which one is the best to treat. Now this is, mind you, that is these studies are done on non-pregnant patients. However, all these medications we have mentioned during the talk that they are safe in pregnancy. So if it is applied on non-pregnant, it should be applied on pregnant women. And by the way, the inclusion in this trial is open. All what you have to do is to enter the WHO site, you register your institution, and you can be part of the trial. From the Arab world, there are 2 countries that are currently participating in this trial, Lebanon and Bahrain. They are participating in this trial. Now, Europe also have a similar trial, and they called it Discovery versus Solidarity. So they are now doing Discovery in Europe. Now, the only difference between the WHO one and the European one is that in the European one, they use only hydroxychloroquine. They don't use chloroquine. Chloroquine is not an option. And we are waiting for the results of the 2 trials to decide which one of the previously mentioned medication is better to treat COVID-19. Now, the convalescence plasma, as we know and you heard in the media, that they take the blood of the people who recovered from the COVID-19, and they take the plasma because the plasma contains the antibodies against the virus, and they inject it into the sick people, particularly sick people, to treat. Now, it showed some advantage, so that the FDA accepted or approved a single patient emergency, still investigational treatment in patient with serious, immediately life-threatening COVID infection. So they specify life-threatening condition and single patient. So they approved it for that. It is not for mass treatment till they find out the safety and the outcome. The donor is a patient who recovered from the COVID-19. The donor have to be in a complete resolution of the symptom, at least for 14 days. Documented negative SARS nasopharyngeal swab and blood specimen of SARS neutralizing antibody of 1/320, which means high titer, so that there is a high or a large amount of antibodies in the plasma from that person. High dose intravenous immunoglobulin is tried only in 3 cases. It is still controversial. The disadvantage of this compared to the convalescent plasma is that the intravenous high dose immunoglobulin does not contain the immunoglobulin that is specific for COVID-19. It contains antibodies. We don't know against what. So it was used only for 3 patients. The benefit is unclear. It is still controversial, and we should see what comes next from this. Despite the fact that myself, I think it is not a valid option because also of the cost. There is a cost behind this, which is very high cost. Monoclonal antibodies are now one of the drug companies are trying to use the monoclonal antibodies, human monoclonal antibodies to treat, and it's experimental. They just started their work. They did not publish or show the results yet. So now the second part of the talk is talking about the progesterone, the tocolytics and steroids, magnesium sulfate, prostaglandin, or induction of labor. The progesterone is easy. All of you are using progesterone, and we use it to treat or to prevent preterm labor. So far there is no evidence that the progesterone has an impact on COVID. So it does not affect the course of COVID. Now, patients who needs this progesterone to continue with their therapy, the progesterone should not be stopped. It should be continued. It should be continued, particularly in cases of mild disease. In cases of severe disease, you might have to take another decision based on the patient's condition. So the use of progesterone in severe cases should be individualized. If you are going to deliver the patient soon, for any reason, there is no point of using it. If there is time, maybe you can use it. Now, steroids for fetal lung maturity. This slide seems to be full, but I will summarize it. The WHO advised that because of the association between steroid and worsening morbidity of the viral pneumonia in COVID-19, steroids for fetal lung maturity should be used in caution. And patients COVID-19 with pneumonia, use it with caution. Now, because of the benefit of the steroids, the ECOG continue to recommend the use of standard steroid between 24 to 33 weeks plus 6 days. So that's it, 24 to 33 plus 6 days, you use the steroids in patient with a suspected or confirmed COVID-19. Put in mind that if they have a pneumonia, you might have to change your decision based on this recommendation. The decision might be individualized. So for now, between 24 to 33 plus 6 days, you use it. pregnancies between 34 to 36 plus 6 days, there is no evidence, or the benefit to the neonate is not quite clear. Therefore, the American College of Obstetricians and Gynecologists has advised not to administer it in this type of cases. And again, the decision is individualized. Tocolytic. There was some reports earlier that showed that some of non-steroidal anti-inflammatory drugs can worsen the COVID disease course. Therefore, giving the uncertainty, we are not sure. There is a contradictory results, but we are not sure. So given the uncertainty, endomethacin or endoseed should be avoided. If you avoid the endoseed, then the next option for you is nifedipine. So nifedipine is the drug of choice to treat preterm labor in patients with COVID-19. However, if you don't have nifedipine and you have beta sympathomimetic, you can use them, but be careful because beta sympathomimetic might lead to increase in heart rate, tachycardia, and if the patient is sick, you are making the patients even sicker. Other tocolytic agent may be used with caution, and just be sure that there is no interaction between the drugs that you are giving as a tocolytic and the medication that have been used to treat the disease. Magnesium sulfate is safe, and it should be given case by case with the consultation of maternal medicine and pulmonologist. Why? Because if the woman with COVID is in respiratory compromise and you are giving her magnesium sulfate, which is a respiratory depressive agent or suppressive agent, you might compromise the life of the mother. So if you are using it either for seizure prophylactic or for neonatal neuroprophylactic, you have to be careful about this. So chronic medications, the only medications that we should be aware or careful about are the immunosuppressive. The immunosuppressive drugs in general will increase the risk of severe disease. The decision to continue with the drug or not should be made with the assistant of the ID people and the primary physician who is treating the patient according to his specialty, whether gastroenterologist or rheumatologist or whatever the immunosuppressive or oncologist, whatever the immunosuppressive agent was given for. Prostaglandin for induction of labor. The prostaglandins are safe. The only problem with the induction of labor is the social distances and the minimization of patient to staff contact. We want to do our best to reduce the patient staff contact. And in order to do this, to reduce the patient staff contact, you have to limit the number of vaginal examinations. So probably for now, if we use the mechanical forms in forms of catheter, inflated catheter, or if you use the 10 milligram vaginal delivery system, might be a good option. Now, can we do an ARM or not? As till now, the virus was not isolated from the amniotic fluid so far. Artificial rupture of membrane and oxytocin is a safe option in patient with COVID-19. Now, the last part of my talk is the thromboprophylaxis. I think that the risk assessment is routine in all the hospitals. So when your patient is admitted, so individualized risk assessment should be done on admission. If venous thromboprophylaxis is indicated, we have the option of the intermittent pneumonic compression, which is safe. You can use it in any pregnant woman with COVID. If the risk of VTE is higher and you have to use the pharmacological agents. It depends on the expectation of the delivery. If the patient is going to deliver soon, within few hours, then unfractionated heparin is a better choice because it's readily, it resolves quickly and there is an antidote for that. If you don't expect your patient to deliver within 24 hours, you can use the low molecular weight heparin. And thank you for listening.
Thank you, Professor Nabeel, for the excellent lecture. Again, lots of important information regarding the medications with lots of recent evidence on all the investigations that are currently being used for patients with COVID-19, whether they're pregnant or non-pregnant, and very important information regarding the usual obstetric medications that we use in our pregnant population. So thank you, Professor Nabeel, for that. So we'll go on to the my presentation, which we will conclude with. But I'd like to reassure you that we will be answering your questions. We have lots of questions coming in. Most of the questions, fortunately, have already been answered. And I'm pretty sure that a lot of other questions are going to be answered in the last part of the webinar in this presentation that I'm about to give. So
if you just allow me, Dr. Yaser Faden, to just introduce you. I'm just going to take 1 second here. Dr. Yaser Faden had led the task force to come up with the SSMFM guidance on COVID-19 and pregnancy, and he was an excellent leader. He's a chairman, Department of Obstetric and Gynecology, and assistant professor of obstetric and gynecology, and consultant maternal-fetal medicine at King Abdulaziz Medical City, King Saud bin Abdulaziz University of Health Science. We are so proud to be working together with Dr. Yaser, and we're going to listen to his part of the presentation today eagerly. Tafadal, Dr. Yaser.
Thank you, Dr. Eman. Allah yatikum al-afiyah. So again, as I was saying, the questions, we will be answering many of the questions you are sending. Lots of the questions, as I mentioned, have already been answered. And inshallah, you'll be able to go back to this webinar once it's posted on the Saudi Commission for Health Specialties website. So this webinar is being recorded, and you can go back to it if you missed any information. So I'm going to be continuing the presentation on pregnancy and COVID-19. Lots of challenges and hopefully lots of recommendations that we can also give based on the best available evidence, even though the evidence is not that much and based on small numbers, but again, it is the best available evidence that we have, and based on that, we are offering the recommendations regarding optimal care for our pregnant women with COVID-19. So I'd also like to declare that I have no conflicts of interest. Now, what I'll be covering in my part is just talking about focusing on critically ill patients with COVID-19. I'll be also talking about some considerations we need to keep in mind for patients with suspected or confirmed COVID-19. And I'll be concluding with postpartum care of patients with COVID-19. So talking about maternal care and a little bit of information regarding neonatal care. So again, this slide you have seen earlier in the presentation with Dr. Alsulmi, the categorization of patients who present to our hospital. So again, just here to focus on those who are critically ill. So usually these patients come in shock or have organ failure or they have respiratory failure that might require mechanical ventilation or having refractory hypoxemia, and some of them might even require ECMO, extracorporeal membrane oxygenation. So we're going to be talking about that. So again, with a critically ill patient, multidisciplinary care is the key. We can never overemphasize the importance of multidisciplinary care. It has mentioned several times already in the presentation by Dr. Eman and then by Professor Nabeel, and I'm going to be mentioning it also several times. So again, we need to collaborate with our colleagues, whether these colleagues are in the medical fields or allied health sciences. So again, lots of collaboration is needed in order to take care of our patients. So multidisciplinary care is very important. Usually with critically ill patients, we take care of them in the critical care unit. So again, this is in collaboration with the intensivists, with the specialist in infectious disease, and possibly others. So when we're taking care of patients who are critically ill, usually the care is individualized according to that situation. So some patients, who present with renal failure, for example, might need hemodialysis, and this is to correct the electrolytes imbalance. Other patients would require respiratory ventilatory support, as we mentioned. They need to be put on ECMO. Other patients need to be put on wide spectrum antibiotic coverage. So again, it depends, and we should be taken, case by case. Priority is always given to stabilizing the maternal condition before doing any type of intervention, especially obstetric intervention. So we need to stabilize the maternal condition. Now, the care that is given with regards to obstetrics, so again, it needs to be, patients need to be taken care of by the most senior obstetrician available. If there is a maternal fetal medicine consultant available in the institute, then they definitely need to be involved in the care of these patients. Critical ill patients would need continuous fetal surveillance, whether that is by regularly checking up on the fetal heart or doing ultrasound if needed. So depending on the condition. Termination of pregnancy, do we need to terminate these pregnancies? Well, definitely we need to take that into consideration. And again, this is a decision that is taken not just by the obstetrician, but also a joint decision taking into consideration, what the intensivist or infectious disease consultants have to say with regards to this patient's condition. So termination of pregnancy might need to be offered in critically ill patients who have a worsening medical condition. So when should we deliver the patients who are critically ill? Well, there are several factors that we need to take into consideration to time the delivery. First of all, gestational age. Also, as we mentioned, the maternal condition, also fetal assessment parameters, and then also taking into consideration the risk of vertical transmission. And we'll talk about each one of them one by one. So talking about gestational age. So again, if this mother who is presenting and critically ill, and her gestational age is still early in pregnancy, so less than 23, 24 weeks of pregnancy, then we can consider termination. Again, if the experts who are taking care of her think that that is the best option in order to improve her condition. For gestational ages between 24 to 34 weeks of gestation. So again, we need to do extensive counseling with the mother and her partner regarding her condition, and also regarding the possibility of morbidity and even mortality. So especially when we're talking about neonatal morbidity and mortality because of early delivery, we need to also talk with her regarding the steroids and the magnesium sulfate. And we heard about giving steroids and magnesium sulfate and being cautious when we're giving these medications, especially in the critically ill patient who has, for example, pneumonia. Then we need to be very careful when we are going to be administering these types of medications. For those who present with a gestational age above 34 weeks, so we need to seriously consider, delivery and when would be the best time to deliver these patients. And again, this has to be individualized according to the maternal condition. So as we said, fetal bradycardia, bringing her all the way to the operating room. So, and making sure that everybody's taking the necessary precautions. Now, regarding home births, so the Saudi Society for Maternal-Fetal Medicine, and not only the Saudi Society of Maternal-Fetal Medicine, so other also respectable obstetrics and gynecology associations like the Royal College of Obstetrics and Gynecologists, they actually discourage home births for patients with suspected COVID-19. Because these patients, just in order to make sure that all the necessary precautions are done in taking care of these patients, it's better for these patients to be taken care of in hospitals. So again, some precautions also when we are taking care of patients with suspected COVID-19, making sure that all the equipment is appropriately covered to prevent as much as possible contamination. Now, this is just a summary of the management of pregnant women with suspected or confirmed COVID-19 in labor. And this can be found in the Saudi Society of Maternal-Fetal Medicine guidance that was distributed recently. So again, the patient, when she presents, she's admitted to an assigned negative pressure isolation room, whether that's going to be in the labor and delivery room or ICU. So, and depending on the severity of the maternal condition. And as we mentioned earlier, multidisciplinary team approach, so everybody needs to be aware, maternal-fetal medicine or the obstetric consultant, ID team, NICU, anesthesia, ICU team if needed. So they should all be consulted upon this patient's admission. And then depending on the patient, she could be, if she has mild to moderate symptoms, then we admit her to a negative pressure isolation room. If she's considered severe or critical, then we might need to admit her actually to the intensive care unit, also in a negative pressure room, isolation room that's fully equipped to conduct delivery. After that, this is the rest of the many points we mentioned earlier. So adhere to local infection control practices, including the PPE, making sure the patient is stable, priorities always for maternal well-being, and then monitoring during labor. And so, as we said, continuous electronic fetal monitoring to ensure fetal well-being. And this is because of studies that showed that a significant amount of fetuses showed compromise during labor. So that's why it is recommended to offer continuous fetal heart monitoring. As we mentioned earlier, avoiding fetal scalp sampling or fetal scalp electrodes. Then giving the labor pain control analgesia, the narcotics, again, used with caution, depending on the mother's respiratory status. Felt that it's not recommended in this current situation, and this is in order to avoid contamination. You will find that if you read the Royal College of Obstetrics and Gynecology guidance, they mentioned that Internox can be used, but again, because it is standard practice there that they have microbiological filters when they are using Internox. So again, here, if you're going to be using Internox, then you need to make sure that you are using a microbiological filter to prevent contamination. So patients with, then again, here we divide the management depending on if the patient is severe or critical, and then mild to moderate symptoms. And I won't go through that. You can refer to that in the Saudi Society of Maternal-Fetal Medicine guidance. Now, regarding postpartum care, and I'll conclude with the postpartum care, and this can be divided into maternal care and neonatal care. So those patients with suspected or confirmed COVID-19 and they're stable with mild symptoms, they can be nursed in the postpartum ward. So again, we need to put them in an appropriate negative pressure isolation room. Those who have moderate or severe symptoms, then they might need to be taken care of in the ICU for respiratory support. For patients postpartum, we need to consider venous thromboprophylaxis. And as we have heard before, COVID-19 is a hypercoagulable state, as is pregnancy. So venous thromboprophylaxis needs to be seriously considered. Again, with regards to postpartum care, we follow the standard guidelines with the medications. We try as much as possible to avoid non-steroidal anti-inflammatory medications. Something that we need to take into consideration is mental health illnesses. So usually severe illnesses in the mother increases the risk of mental health illnesses. It has been found that severe maternal morbidity increases the risk for psychiatric disorders. So that's another reason why we need to observe the occurrence of any mental disturbance in the mother. Another reason why we need to look for mental health illnesses is because of the maternal neonatal separation that might occur because of her situation, and this can cause anxiety or even maternal depression in the mother. So emotional, psychological support and counseling should be provided, and there should be continuous monitoring for postpartum depression. Regarding contraceptive counseling, so usually it's the standard contraceptive counseling in these patients, no difference than non-COVID-19 patients. Neonatal care, so regarding the mother neonatal contact, so the maternal health status is a very important factor in determining if the mother and neonate can come in contact with each other. The issue of separating them has to be thoroughly discussed with the patient and her family, and probably individualized care is recommended. Now, there is a lack of consensus regarding mother neonatal contact, and there has been lots of questions already by you regarding breastfeeding. Can the mother breastfeed? Can the baby be with the mother after the delivery? So we're going to be addressing this right now. So there is lack of consensus regarding the mother neonatal contact. Infants born to patients with confirmed COVID-19 are considered suspected cases. So these are suspected infants, and studies have shown lack of consensus again. So the Chinese, the practice there is that they separated the newborn from the mother for 2 weeks. The Royal College of Obstetrics and Gynecology guidance, they recommend keeping them together, taking all the necessary precautions. But the American College of Obstetrics and Gynecologists, the Society of Maternal-Fetal Medicine in the States, and the Center for Disease Control, they recommend temporary separation of confirmed or suspected cases of COVID-19 until the mother's transmission precautions are discontinued. The Saudi Society of Maternal-Fetal Medicine, they prefer to err on the side of caution, and they advocate separating the mother from the neonate due to the risk of contamination. So regarding secretion in breast milk, so there is no evidence that the virus is secreted in breast milk. But as I just mentioned, direct breastfeeding is not recommended due to the risk of contaminating the newborn. The Saudi Society of Maternal-Fetal Medicine recommends a detailed discussion with the mother regarding the risks and benefits of breastfeeding, also mentioning to them the limited available data on excretion of virus in the breast milk. And as mentioned earlier in the first presentation, the presence of antibodies in the neonate, IgM, which shows that the neonate does have a response to the virus from the mom. Risks of infection have to be also in the discussion with the mother, and also discussing alternative feeding options like express breast milk, for example, or formula feeding. So with that, I'm going to conclude this webinar, and I'll conclude with a great big fat thank you to all the healthcare workers that are on the front lines of this coronavirus pandemic. So each and every one of you, a big thank you. We are right now, but inshallah, we will all be overcoming it in the near future. So with that, we're going to be going on and answering a few questions that were presented. Dr. Eman, Professor Nabeel, if you have anything you would like to add before going over the questions.
إذا تسمح لي ياسر, there's a question here from Samir Ahmed. He's asking, what is the evidence of acquiring the infection patient to doctor during conducting a normal delivery? And a second part of the question is there any evidence that the infection is transmitted direct contact with body fluid? Now, to answer this question, there was previous literature, in the previous literature on SARS, not SARS-CoV-2, but SARS-CoV-1. It was isolated, the virus was isolated in the vaginal mucosa. And in SARS-CoV-2, it has been isolated in the stool, maternal stool. And we know during delivery, patients sometimes do have bowel movement. With the current literature, there is no fecal-oral transmission yet be reported in the literature. As if it comes to the amniotic fluid, the study that was done by Chen et al. From China, he did it on 9 pregnant women, and all of them had amniotic fluid tap done and the chordocentesis done to the fetuses, and none of them came back positive. So from that study, we don't think amniotic fluid splat would cause the transmission, since we don't think the virus is present in the amniotic fluid. With the current pandemic, we do recommend full PPE, using goggles, using your water protective scrub or sheet, and then using gloves, as well as surgical mask for all patients, and using the respirator N95 for patients who are COVID-19 suspected or confirmed cases. That's my answer to the question. And I think there was other question.
Is there another question that was, yes? There was one question to Professor Nabeel. Professor Nabeel, do you recommend any of the medications you talked about with patients with COVID-19? So let's say if a patient with COVID-19 presents and she needs treatment. Based on your extensive review, which medications would you be recommending?
وطبعا evidence اللي موجود is very limited. And most of these medications are investigational, still investigational. Some of them experimental and some of them investigational. Now, which one to use depends on, number one is the authorities in the region that you are in. What are their recommendations? MashaAllah, Wazarat al-Sahha are working very hard on this, and they are putting very specific protocols for the treatment of COVID-19 based on the available data and based on the available medication that you have. And some centers, they will have chloroquine or hydroxychloroquine, and they don't have the anti-HIV medications. So yes, you can use the hydroxychloroquine. If you have the anti-HIV and the interferon, use that. But to start with, you should follow up the authorities' recommendation, which drugs to use. And the Ministry of Health, they distribute to each hospital the preferable medications based on the evidence and based on the availability of the drugs.
Okay, thank you, Professor Nabeel. There's a question here by Ahmed Ali. Who will be the MRP, the most responsible physician if a pregnant patient with COVID-19 is admitted? Will it be under internal medicine or obstetrics and gynecology?
In my opinion, obstetrician and gynecologist. And we have discussed that, Dr. Yasser and Dr. Eman, you remember in one of our meetings, we discussed who should take care of the patient and who should follow her up, not only who should take care of her, who should follow her up. Yeah. There is a difference between patients who comes not in labor and patient who comes in labor. Patient who comes with not in labor should be followed up by a multidisciplinary team and the most experienced consultant. Patients who comes in labor, I think to minimize the patient staff encounters or to promote the social distancing or to limit the number of patients of staff exposed to that patient, whoever is admitting that patient in labor, whoever is taking the decision for that patient, whether to deliver vaginally or cesarean section, should look after her till she delivers. Number of people exposed to one patient. أما البيشنت اللي جاية not in labor, as I said before, multidisciplinary team, and it should be a senior obstetrician if MFM is not available. If MFM is available consultant, he should take care of that patient. طبعا in collaboration with the other teams from the other specialties.
Yeah. So to add to what Professor Nabeel just said, so definitely if the patient is presenting to the hospital due to an obstetric cause, then yes, most likely the most responsible physician will be the senior obstetrician. While if the patient presents due to a non-obstetric cause, she's having symptoms or signs of COVID-19, then it depends on your institution. I know lots of institutions, these patients would be admitted under either the infectious disease consultant or internal medicine in order to be treated for the COVID-19 or to be worked up and or treated for the COVID-19. And of course, any care is concurrent care and involving other healthcare workers as needed.
So there was a question, or actually multiple questions asking me about the case fatality rate and how come some reported 0, and although there are some, especially in Egypt, they were commenting that they had some cases, maternal mortality. Case fatality initially that was presented 0% were by Dashrad, and they did not include the Iranian case in it that was just published a couple days ago. And he also asked if there was any comorbidities with that patient. That patient was young, healthy. She was only 27 years old, didn't have any comorbidities. She was admitted 3 days earlier to a maternity hospital, and she was complaining of sore throat, congestive symptoms, upper respiratory tract symptoms, and wasn't treated appropriately. And then when her case got deteriorated, was transferred to the bigger institute. Yes, if you think there was reported cases in Egypt or other areas that was published in the media and it wasn't published in the medical literature, these ones were not included in the statistics that was presented in this webinar today. And I encourage people, if they do have cases, to please do report them and write them in literature to enrich our knowledge as well.
Dr. Eman, there's a question here. It says, is there any role for outpatient isolation in a symptomatic pregnant patient with COVID-19 before having 2 consecutive negative swabs? Or having 2 negative swabs, or is having 2 negative swabs mandatory before discharging the patient, even if she's asymptomatic?
Okay, now if we look at the algorithm for the Ministry of Health, if patients were asymptomatic and they were positive, they were actually isolated. They were isolated at home before having the positive result when they were just suspected cases. And once the swabs confirmed positive, they were isolated. If they were asymptomatic, they were isolated in a facility according to the availability and the recommendation of the community health an infectious disease specialist that was oversighting these cases. For pregnant patients, and because we do know little on these cases, as a society, we recommend for these ones to be admitted and not get discharged until we have the 2 negative results that's 24 hours apart, and then continue the isolation for the complete 14 days if they were discharged prior to that.
Thank you, Dr. Eman. There was a question here regarding COVID-19 and the recent evidence showing that it's associated with thromboemboli. And as I mentioned in my presentation, that COVID-19 is a hypercoagulable state, and knowing that pregnancy is also a hypercoagulable state. So they're asking, should we consider thromboprophylaxis for 2 weeks after postpartum, regardless of their VTE score? And what would be the Saudi Society of Maternal-Fetal Medicine opinion on this? So, I can give my take on this, and then Professor Nabeel, Dr. Eman, if you have anything also to add. Now, we didn't mention a lot on thromboprophylaxis in our guidance that we distributed a while ago, and because at that time, the evidence on the thromboembolism, the increased risk of thromboembolism didn't come until actually after we distributed our guidance. So that's why we didn't elaborate that much on it. But I mean, seeing the evidence now as it surfaces, I think that COVID-19 is considered a significant risk factor for thromboprophylaxis, whether that is antenatal thromboprophylaxis or postnatal thromboprophylaxis.
Yes, Yasser. One of the theories behind the pathophysiology of the disease, it's a theory still. We don't know what is the exact pathophysiology, that it causes microemboli in the lungs of the affected patients. This is one of the theories beside the other 3 or 4 theories. But we don't know whether this theory is true or not. If it is true, we are covering for it. If it's not true, I don't think we lose anything by giving the patient prophylactic.
Okay, thank you, Prof. Nabeel. I'm going through the questions. Did you pick up any questions that need to be answered? So as I mentioned earlier, lots of the questions were actually answered. So again, a question for Dr. Eman. You mentioned, the suggested antenatal care visits during the COVID-19 pandemic. The suggestion regarding the frequency of visits, this is mainly for low-risk pregnancies. How about high-risk pregnancies? Can it also be applicable for high-risk pregnancies?
So we can always adjust our prenatal visits somehow to balance between social distancing and still for our high-risk population, still see them frequently, or at least be in touch with them and contact them more frequently. The SSMFM has, the Society of Maternal-Fetal Medicine, the American one, has actually published along with the ISWAG a guidance on how frequent, and they reduced the frequency of visit for high-risk population. If you're following someone for IGR, you're following someone else's for maternal diabetes, and substituted some of the visit that required longer visit, like doing a CTG by just adding biophysical profile to the ultrasound. So it can be modified, but it has to be individualized to each patient. And try as much as possible to minimize the visit, but still not compromise the patient health and outcome.
All right.
And if you allow me, actually,
yes.
Question asking about maternal pyrexia early in pregnancy, and if that's affect the fetus. Now, the majority of cases that they were reported, they were later in gestations. of COVID-19 were, but there are still some cases that they were reported early, and we're still following these patients, and we don't know what is the outcome. Therefore, we're recommending the ultrasound anatomy scan to look for any congenital anomalies. But we do know that the fever with median temperature of about 38 to 39 is the prevailing symptoms of COVID-19. And there was a cohort of studies in patients with other infectious disease who actually not showed increased risk of congenital anomalies when they had high temperature early in pregnancy or maternal pyrexia in the first trimester. Although there are some reports talking about maybe childhood attention deficits or spectrum has been related to hyperthermia injury to the fetal neurons, but hasn't been documented yet. So the short answer, we don't think there's, up until now, there is any major congenital anomalies could result from maternal hyperthermia early in the first trimester. Other than what we always talk about, the open neural tube defect, that might be a result for that, but nothing that's been reported in relation to these cases yet.
Okay. Thank you, Dr. Eman. So, Professor Nabeel, any last remarks before
yes,
we
there is a question here of a 32-weekers that was admitted to the hospital because of pneumonia, as mentioned by the question. And she thought she had an X-ray and she had COVID-19 testing, and all the tests were negative. So she's just pneumonia in pregnancy. She was given antibiotics in the form of ceftriaxone, I think, and azithromycin. And she was discharged. She's still complaining of some cough, but she's improving. Now the question, she was advised by whoever is taking care of her to start steroids like prednisolone for 40 milligrams for 3 days and taper it down. So it's a course of steroids that are not intended for, I'm sure it's not intended for fetal lung maturity, because this is not the protocol for fetal lung maturity, and it will not work. We know that most of the prednisolone does not cross the placenta, so it does not give the effect of the betamethasone. So I'm not sure why she was given the corticosteroids. And the question, does she have to is it safe to take this medication, number one? Number two, does she have to repeat the COVID-19 for the third time? I would like to know from the one who asked the question, what was the indication for steroid? A patient who had pneumonia, and she was given antibiotics, and she was improving by those antibiotics. What was the indication for the steroids? I'm sure the physician who gave the steroids had a point. So in this case, the physician who is prescribing the steroids should weigh the benefits versus the risks. If the benefits for her is more, I don't see any problem in taking that steroids. If there is no benefit from that steroids, it's better to avoid it if no need for that. But if she needs it for a specific medical indication, she should take it, no problem. For the repeating the test, also I'm not sure how far they repeated the test, excuse me. Did they repeat the test only after 42 hours, or they repeat the test in different times? Now, some of the recommendations for the Ministry of Health indicate to repeat the second test is after probably 72 hours. So if they repeat it after 24 hours, I will do it after 27 hours. But if they did it after 27 hours, it's probably okay not to repeat.
Well, thank you, Professor Nabeel. I think we are out of time now. So with that, we would like to conclude. Any final remarks by our speakers, Professor Nabeel, before we end?
I will conclude with what I started. We thank greatly the Saudi Council for Health Specialties for giving us the opportunity to present and to distribute the knowledge among physicians in our country. and we say جزاكم الله خير والله يجعله في ميزان حسناتكم. برضو كمان we thank the Saudi Society of Maternal-Fetal Medicine. They did lots of work and they communicated with the Saudi Council to make this webinar comes true. And we hope we will do more and more of not only COVID-19, but any other hot topics, inshallah. Thank you.
Thank you, Professor Nabeel. Dr. Eman.
Again, I'm just going to thank everybody else. Thank you for the Society of Maternal-Fetal Medicine, Saudi Society. I also want to thank every single person of the task force. Shukran, Dr. Samiha, Dr. Fadwah, Dr. Nabeel Bondagji, Dr. Hythem, Dr. Yaser, Dr. Yaser Faden, and Dr. Yasir Katib, and Dr. Yasir Sabr, and Dr. Nadia Alghilan for working so hard day and night over the weekend while you're running between the labor floor, attending the meetings and working hard to accomplish and finish the guidance in a short period of time. And we are working together again to updating these guidance as the knowledge is updating frequently. Inshallah, that's about it.
Thank you, Dr. Eman. So again, I also would like to thank the Saudi Commission for Health Specialties for hosting this webinar. I would like to thank specifically Dr. Wissam Abu Znada for inviting us to speak to all the Saudi Arabian audience regarding pregnancy and COVID-19, the challenges and the recommendations. I would like to thank all of you who have stayed with us now for almost 2 hours to listen to us, and we hope that all the information we presented to you was very beneficial and will make a change in your practice. So thank you all very much, and good night.
يعطيكم العافية جميعا، وشكرا مرة ثانية لأستاذنا بروف نبيل وأختنا دكتورة إيمان وأخونا دكتور ياسر. الله يديكم العافية وينفع بعلمكم. ويبنار الحمد لله ما شاء الله ناجح من الانتراكشن اللي شايفينه، وما شاء الله 10,000 sustained all through الويبنار. الله يوفقكم، هذا الماكسيمم حق زوم. الله يوفقكم ويكتب أجركم وينفع بعلمكم إن شاء الله، وشكرا مرة ثانية لوجودكم.
جزاكم الله خير.
جزاكم الله خير.
شكرا جزيلا.
شكرا.